Thank you very much for the invitation to be here with you guys today. It is, by my count, 7:50, so I have 20 minutes to go through about 300 slides, so we'll see how that works out. I want to talk a little bit about historical perspective, and I'm glad Dr. Jonas is here today. I haven't seen Howard in 10, 15 years, and it's interesting to hear him speak because it's almost like we reach similar conclusions up to a point by coming through different pathways. Some of the practical aspects of the use of this technology, from our point of view, fundamental concepts, our expectations, some of our findings and hypotheses, and I may actually leave you with more questions than I leave you with answers, but there's a reason for that, and we'll cover some of that. Now, I've never been accused of being politically correct, and I don't intend to start today. But that said, I'd like to give you my perspective on things. Now, why am I here? I'm here because I live in that shadow world that is the intersection of interventional neurology, vascular neurology, and neurocritical care, which gives me a rather unique perspective on things and how things work and how things are to be done. We live in a different world in the cath lab than we do in the intensive care units, and I'm going to show you some of the differences and how, in fact, they can apply to some of what we do and how we do it. When I was invited to speak, the original title of the talk was said to be Time is Brain, which is based upon something I wrote a long time ago and probably in a galaxy far, far away. But there's a lesser known editorial that I wrote in 1997 where we started doing some of the physiologic assessments that cardiologists do in the coronaries to the brain. And to give you an example, it was our contention, for example, that two lesions that angiographically could look exactly the same, to the same degree, could be studied physiologically, in this case with a pressure wire made across the lesion. And you can see the lesion on the right side has a significant pressure gradient, and the lesion on the left does not. And I think this is something that we postulated should be integrated into what we do. And in fact, over the course of the years, we have seen how measurements of blood flow have become more and more exploited. Dr. Jonas has been a pioneer in measuring blood flow. And we are now at a point where in 2014 we are having this technology that is in front of us, which is ultrasound tag near-infrared spectroscopy and how it allows us to do things. With that introduction, here's what I think are the main differences between what we do in the cath lab and the neurointensive care unit. In the cath lab, we do a lot of elective work. Some of it is urgent, and we'll talk a little bit about that. But in the NICU, most people who end up there as patients don't do so by choice. There's not sort of appointments to get into the neurointensive care unit. In the cath lab, we have a much more controlled situation, and some of the things we do are induced by what we do, and I'll show you some examples of that. In the NICU, we're more reactive to the natural history of the illness. And in the cath lab, we have more regional control of circulations because our catheters and devices are in those circulations, while in the NICU, we're more at the mercy of the entire body. Also, one of the biggest differences that I found, and bear in mind that we got this device for measuring non-invasive blood flow about 12 days ago today. So I've just been test driving it for 12 days, so bear in mind that some of what I have to say today may be quite rudimentary in some of my analysis. But I find it quite challenging, the differences between the fact that in the cath lab things move very rapidly in seconds and minutes as opposed to hours and days. Practical issues. The first thing was, where do we put this thing? We have devices, we have to be able to see it, but at the same time, how much do we want to see it, and is it interfering? So at first we tried in front of us where all the other monitors are. That proved to be not very beneficial, and we finally found that having it on the side, particularly with a biplane room, works much better, and it allows the personnel to actually manipulate the device too. The probes, and the company is working on making this even easier. In my opinion, eventually the goal should be that this is plug and play. It has to be that way in order to make it feasible. But we were concerned that the apparatus would be interfering with our imaging. And in fact, this is what they look like on a fluoroscope. Guess what? It doesn't. Not to any measurable or material degree. This is an angiogram. You can barely see the monitor sensors on the AP view. This is a standard Caldwell view, which is what we do. Even if you were to say, well, there's a small aneurysm sitting right behind it, all you have to do is angulate the AP tube differently and you'll get a better shot. In the lateral, it's essentially a non-issue. You can see it in the top left of the screen. That's where the probes sit. So there really is not a problem. And that was one of the first practical issues that we wanted to get understood. So our challenges were, I think Dr. Jonas is absolutely correct when he says about we need absolute blood flow measurements. And I thought the same way. However, when I started looking at the data, I began to get intrigued by the possibility that in some instances, absolute measurements of blood flow are a must, while in others, there may be some way around it that can tell us how things work or how things are in the patient in different ways. I am convinced after I've been looking at data now for days, every one of these patients, and mind you, these are short procedures. We're talking about 15, 20 minutes procedures. We have thousands of data points. The graphs are staggering. The spreadsheets are amazing. We need a standardized way of analyzing the data so the data becomes comparable and reproducible throughout every center and throughout the world so we can then conduct large studies of what we're trying to do and how to use the equipment. As luck has it, the first case we had when we had the machine, the same day they delivered it, was we had a case on our EP lab where they were implanting an defibrillator. And one of the things that happens when you implant a defibrillator is you have to test it once it is implanted to make sure it works. It would be a shame for the patient to die of a malignant arrhythmia after going home through that procedure. During the device testing, essentially what happens is you induce VFib arrest and the device shocks the patient and it's working and you prove the point. This graph, when I first started looking at it, it completely baffled me. And I don't have all the answers, but I used it as a framework to put together what I think we should be doing in the future from my point of view. Notice that the flow does not go to zero. Why? If the heart has stopped, why is not the flow going to zero? I have a real problem with that. And I don't know the answer to it, but I have some suspicions, but I think it's something that needs to be explored. Why does this happen? Is this a problem with the sensitivity of the instrument, or is it simply, as Dr. Jonas says, that we really don't know as much as we think we do about microvascular flow in the tissue level? So I thought of, if you look at, interestingly about this graph, you'll see that you can actually divide it into segments, which is, I think, what we should be doing in the future to try to analyze this data. There are intervals and there are magnitudes of measurements. When anything happens to the flow and it drops, there is a time to which the maximal drop occurs, and then there's a recovery when flow is restored. When this happens, then many times, as we will see, there's an overshoot, a compensatory overshoot, until the system stabilizes. And it is my opinion that looking at these intervals and looking at these measurements is probably the best way to do this. So I started doing that in the cases that we did and see what I could come up with. I did a couple of other things that I thought were more interesting to me too, which is, number one, I started comparing the measurements to an average of the baseline of 50 consecutive measurements prior to the event that I was trying to look at, and using that baseline as the 100% mark where flow is normal and see how much it deviates percentage-wise and proportionally from that baseline. And this is basically what we did in that particular case. Is you can tell that for every wave, for every event, you can get a percentage of the maximum drop, in this case 38% drop, occurring within 29 seconds of the baseline, recovery over 22 seconds, and overshoot of 13% and the rest of it is self-explanatory. So how do we use this from our point of view in the cath lab? Well, one possibility is to diagnose and select patients based upon the measurement and knowing whether lesions in fact are affecting blood flow or not. Monitoring procedures. I'll show you what happens when you put a balloon in the carotid artery to some of these measurements. Wouldn't we like to know whether the measurements, once you blow the balloon up and you put the balloon down, that the flow is restored properly? Post-procedural care. One of the things that I'm going to raise is what happens when you revascularize the system and there is loss of autoregulation with reperfusion and the possibility of reperfusion injury. I think these are real questions from our point of view. Now, going back to the path of what we've done, Cole Giller a long time ago in the 90s showed that actually with transcranial Doppler, if you close the carotid and you release it again, there's an overshoot like you see on the left on the vessels that autoregulate versus the ones that don't autoregulate, the vessels, for example, in an AVM. So I figured, can we do something like that? Can we do some physiologic measurements for this? And can we do it pharmacologically? For many years, from the early 90s, there has been a body of literature using certain medications during coronary catheterization and even transesophageal echocardiography to look at coronary flow reserve. The idea is that if a lesion is compromising flow and reserve is zero, it's a much worse situation than if there's still reserve, as you will see when it's possible to still vasodilate that bed. We did some of that work in the carotid back in the 90s, and you can tell, for example, the vessel on the graph on the left side is a vessel that with a Doppler wire, when given a medication, in this case we were trying different medications, it still vasodilates, while the one on the right does not, implying that the reserve is essentially exhausted. So we found one normal subject in the last 12 days or so, and we decided to inject the carotid with a variety of vasodilating drugs and see what kind of response we got out of this system based upon what we did with Doppler. I'm pointing out to you the interesting thing about it that just occurred to me today is that the procedure really started where it says lidocaine. So this patient was on the table for some time, and there's all kinds of things going on, and you have to be careful when you're measuring certain these parameters. We have tried, like we did in the 90s with the Doppler wire, nitroglycerin, nicardipine, and nipride. And we found very variable responses. Even when you close it up, it's very difficult to follow. And this is one case alone. But I want to bring it to you in the context of the fact that one of the things Dr. Jonas says that intrigued me is that, in fact, there are some changes in blood pressure. Some of these medications are powerful hypotensive agents. And the secret, I think, is going to be to find a combination and a dosing agent that can vasodilate the brain arteries without causing systemic hypotension, because the hypotension you're causing is interfering with your measurements. And that's something that I think it's an area of significant potential research in the future. But let's talk about other things. Let me show you a case of a patient with a right internal carotid artery stenosis, which you can see in the image on the left, who has somewhat good collaterals. You can see collaterals coming from the vertebrovascular system and also from the left side to a lesser degree. This is what happens during carotid stenting. Now, the period until the end of the green arrow is when we do the diagnostic angiogram, which we do and then convert into a stenting procedure. And I placed it in there just to realize that the procedure itself is actually very short. We put a protection device, pre-dilate, put a stent, and post-dilate. I'm going to show you some of the data. This is balloon inflation and balloon deflation, and you can see the blue line is the right side, which is where the balloon is, and the left side is the red. And you can say, well, wow, the right side flow is dropping, and the other one is kind of staying at the same time. Look what happens when you subject this raw data to the analysis that I described earlier. What happens is that, in fact, there's very little difference between the two sides. The maximum excursion drop is about 16%. The the area on the only major difference that we saw on this one is, if you see, is the overshoot is 26% on the right side, and there's no overshoot on the left. So clearly this person vasodilated, and then when you restore flow after the balloon deflation, the flow overshot for some time. As opposed to this other individual. This is a patient who has a left internal carotid artery stenosis, who essentially has a trapped system. There is no flow from the other side. There is no collateral. You can see there's no anterior cerebral artery. And you can see there's no flow from the right side either. Same thing. Balloon inflation occurred at this time. This is the raw data. Again, a very similar type of curve as the raw data from the previous study. But look what happens when you subject it to analysis. There's a huge difference. The left side carotid, the carotid that was operated, if you see, it has a much more pronounced dropped. It has a much more pronounced overshoot, 13%. It's still not as much as the one we saw in the previous case. There is essentially no overshoot. There's essentially almost no changes in the right side in terms of intervals and magnitude, because they're not connected. In the previous case, it is not uncommon for us to see patients that when you put a balloon in the carotid, guess what happens? The blood pressure drops. So they all relate to each other. Now, the crossover is the only one we've seen so far in a handful of cases. I'm not sure whether that's good or bad. I'm not sure whether that means that the perfusion compensated correctly, or whether, in fact, this is a patient that may be in danger for reperfusion, especially when home the next day, nothing happened to him. But I wonder, if we begin to see patterns like that, what's going to be our future? So hypothetically, I give you the following. It is conceivable that by doing this analysis from these flows, we'll find that different kinds of arterial patterns, different kinds of hemodynamic situations or scenarios will have different kinds of patterns in these intervals that will allow us to recognize them, particularly in the sense that we can actually treat the patients better with that information. And then one final word about acute ischemic stroke. It's not something we want to do. We'd rather prevent than treat, but when it needs to be treated, it needs to be treated. So the question is, what are we going to do with this technology? And we haven't had any cases in the last 12 days, so I don't have anything to show you of that, but I'll give you my 2 cents worth. When we have to intervene and open let's say a carotid occlusion like this, and remove clot and improve perhaps the outcome of the patient, how can we monitor that patient? Well, intriguingly enough, for many years, some of us have actually thought that the difference, that brain ischemia is similar to local brain shock, in the sense that oxygen uptake remains relatively constant within certain boundaries because oxygen extraction rate goes up. And there is a point where the oxygen extraction rate is exhausted and it can no longer compensate, that it becomes flow dependent, and this is where I think some of the commentaries that Dr. Jonas made are right on target. Because it shouldn't be our ticket to actually get these patients, to move them from the left side of the curve to the right side of the curve, to create a much better metabolic environment. So in conclusion, non-invasive monitoring of cerebral blood flow is now feasible and is applicable to a variety of scenarios. As I said, I still have more questions than I have answers for you, but the strategy it leads to a very promising outlook. I think that we have been waiting for this technology for years, and it's here now, and I think it behooves all of us to take charge and use it. And finally, this is the only piece of data I have on absolute blood flow, which should be self-explanatory, which tells you who has the bigger blood flow around. And there should be absolutely no doubt in your minds. And I'll answer some questions later. Thank you.